Well, good evening, everyone. My name is Carla Deal. I'm ACHA's Peer Mentor Coordinator, and it is my pleasure to welcome you to tonight's ACHA webinar, Hot Topic, Menopause in Adults with CHD. We're so excited to have so many of you here tonight. Next slide, please, Kristen.
Of course.
Thank you. I'd also like to thank our sponsors, Abiomed and Johnson & Johnson, for their support of this webinar through an unrestricted educational grant. As a reminder, the webinar is being recorded and will be available to watch again later this week. We will take questions and comments throughout the presentation, and you can send those through the Q&A folder on your control panel. We will answer them after the presentation, and we ask that you keep your comments and questions general and remember that the webinar is recorded. Our speakers can't answer any questions or make comments regarding your specific CHD diagnosis or treatment. Those questions and comments should be discussed with your ACHD team. Since we have a very large webinar tonight, if we are not able to answer your question, please reach out to your ACHD team, but we will certainly try. Closed captioning has been enabled. If you wish to use it, you can click on the Show Captions CC on your user panel. You can also disable it at any time. With that said, it is my pleasure to introduce tonight's speakers and patient representative. Kristen Andrus is a graduating pediatric cardiology fellow from Stanford Lucile Packard Children's Hospital. Dr. Nitra Rumpf is an ACHD board-certified cardiologist at Stanford since 2013. And Kathleen Tischer, our patient representative this evening, is an ACHA peer mentor. It is now my pleasure to turn the webinar over to Kristen and Anitra for their presentation. The floor is yours. Thank you.
Thank you, Carla. So Anitra and I are very excited to discuss a topic that is near and dear to our hearts, menopause, and in particular, how it impacts patients with congenital heart disease. So today we're going to define menopause. We're going to walk through all of its various stages. We're going to discuss some common menopause symptoms, and we'll make sure to highlight which may mimic cardiac symptoms or have interplay with your heart health. We'll review treatment options to address those menopause symptoms, and then we'll explore how menopause impacts acquired heart disease. So menopause is defined as having 1 year straight where you have no periods. After that year, you don't have periods anymore. You can no longer become pregnant. This is a normal part of aging caused by decreasing hormone levels and is usually going to occur sometime in the mid 40s to 50s, with most women in the US going through this transition in their early 50s. However, the change from having regular monthly periods to not having a period anymore lasts way longer than a year and has many different stages. So here we see that menopause is actually broken down into 5 different stages. The hot pink line is representative of your hormone levels. So you can see here when you're having regular cycles still that there's this very normal regular fluctuation in your hormone levels. As you start to enter the earliest stages of menopause, you go on this wild roller coaster ride where hormones are going up and down erratically. And then as you get closer to menopause, those hormone levels slowly drop and then stay low. How long you spend in each of these phases varies woman to woman, but let's talk about them each in a little bit more detail. So the earliest stage of menopause is called early perimenopause. This can happen anywhere from 5 to 8 years before you hit menopause and have that last period. And what most women will notice in this phase is that their periods become irregular. So they might start a cycle early or late. It could last a lot longer or shorter than what they're used to. After this, they transition into late perimenopause, where your periods become even more irregular. You start to skip. You may go several months in between your cycles. This stage is usually somewhere from 1 to 3 years before you have your final period. And it is common to start to have some menopause symptoms like those hot flashes and night sweats starting in this phase. Next, the first 5 to 8 years after your final period is early menopause. Here, menopause symptoms usually continue. They tend to get gradually better with time as your body is adjusting to the lower hormone levels. But how long it's going to take for those symptoms to become manageable or to fully go away, again, is going to vary person to person. This is the time when women are most likely to start treatment if they're having bothersome symptoms of menopause. And if they're starting hormone therapy to address their symptoms, this is the time period where it's safe for them. We can look at some of the common symptoms of menopause. You can see that a lot is changing. There are over 30 recognized menopause symptoms, and up to 80% of women are going to experience some type of menopause symptom as their body, again, is going through all those transitions and adjusting to lower hormone levels. We're going to talk about a couple of the most common ones in a little more detail. So the most common symptom occurring in 3/4 of women is going to be hot flashes or night sweats. And I think this is what people classically think of when they picture menopause. So your hot flash is that brief, intense wave of heat in your face and chest and neck, and you get all sweaty and flushed. And then night sweats are really just hot flashes that happen at night and are annoying because they can keep you awake, wake you up, overall make it hard for you to sleep. We, as doctors in the medical community, lump hot flashes and night sweats together into a term called vasomotor symptoms. And overall, we expect on average, someone who's having vasomotor symptoms, those could last anywhere from 7 to 10 years. It's also very common to get changes in your urination and in your vagina as you're going through menopause. And this is because as your estrogen levels drop, the tissues of the vagina get thinner and drier, and your pelvic floor muscles relax. So you may have frequency, needing to pee more often, incontinence or leaking of urine, and frequent urinary tract infections. You may also experience pain, itching, or burning of the vagina, which could contribute to pain or feeling uncomfortable during sex, which may make your sex drive lower than it was before, a decreased libido. I think these symptoms can be sometimes embarrassing or stigmatizing for women to talk about, but there are really great and safe treatment options that we don't have to worry about any heart risk for. I like to highlight that because unlike some of the other menopause symptoms, like those hot flashes and night sweats, usually these don't tend to get better with time. And you may actually not experience them in early menopause and start to experience them as you're getting further out. I also think it's really important to talk about the urinary changes and feel comfortable discussing those with your doctors. In the past, when I've spoken with women who are in this menopause stage, they might have been on water pills like diuretics or blood pressure pills that make them pee, and were too embarrassed to bring it up themselves, but admitted, hey, doc, now that you ask about it, I actually have stopped that medication or been skipping doses because I'm having issues with leaking or needing to go really frequently. Right. And for patients like us who have congenital heart disease and are on these medications long term, I'd much rather you have the talk with your doctor and get on a medication that's going to address the cause than trying to be a bandage on the symptom by playing around with your heart medications. Menopause can impact our memory and our mood. So estrogen supports creation and retrieval of memory. And it's normal to have some mild memory changes with menopause. You could experience some forgetfulness, slight difficulty with common everyday tasks, and we call these brain fog. I mention these because I think anytime we're aging and having changes in our memory, there can be a lot of anxiety. Am I getting dementia? Did I have something bad like a stroke happen? So I want to give you some examples of what are things that would be totally normal to chalk up just to menopause. Things like having trouble remembering the name of someone you just met, struggling to find the right word to use, forgetting what you walked into a room for, or losing your glasses and realizing they're right on top of your forehead. Those are things that would be kind of within the realm of this brain fog. Things that are beyond that, you want to talk to your primary care doctor about to see if there's something else kind of deeper going on. Additionally, for the mood changes, I think we're all familiar to this idea that after you have a baby and you're postpartum, you get this whirlwind of hormones that can cause your emotions to go wild. and can put you more at risk of having depression or anxiety. Similarly, all the whirlwind of hormone changes you're having at menopause also can put you at a higher risk of developing depression or anxiety, even if you never had a mood disorder in the past. I think this is really important for us to know because we know that things like depression and anxiety are more common in patients with congenital heart disease than in the general population. So we have some population that's already a little bit higher risk, just making sure to check in with yourself and paying attention not only to your physical health, but your mental health during this time. Fatigue. More than half of women, when they go through menopause, are going to experience low energy levels. There's a lot of reasons for this. So if you're having night sweats, that can make it really hard to get good, restful sleep. And then mood changes like depression can also impact your energy levels and sleep. There's a lot of things in general that can contribute to fatigue. And then this is another reason why it's great to have a good primary care doctor who can help you work through these things. But I think importantly, and sometimes under-recognized, there's higher rates of sleep apnea in women that have gone through menopause. We also know that sleep apnea is more common in adults with congenital heart disease. And sleep apnea isn't something that just saps your energy. It can also put stress on your heart and impact your long-term heart health. So if you're having new fatigue, specifically daytime drowsiness where you're drifting off really easily, you should mention this to your care team so they can kind of rule out that sleep apnea isn't something that's becoming bothersome for you. And finally, a symptom that I think is not discussed as much, but actually occurs in about half of women at some point during menopause, are palpitations and dizziness. This is most common when you have, if you remember, that crazy roller coaster of hormones in early perimenopause. And this is because the heart's conduction system is sensitive to hormones. So when your hormones are going on this crazy roller coaster ride, you can get these fluctuations and changes in your heart rate, or sometimes rare early beats that you sense. It also happens with hot flashes that women may notice their heart is racing. There have been some studies in women with structurally normal hearts who've expressed they're having palpitations in menopause, and they showed that those women, their palpitations were benign, meaning they weren't having a dangerous or new heart rhythm. But we also know that we're a patient population whose hearts were built differently and may have some existing rhythm issues. So if you're noticing that you're getting new palpitations or worse palpitations, you should definitely bring it up to your cardiologist just so they can do a screen and make sure there's no new rhythm issue acting up for you. We can talk about some treatments that we use to help manage symptoms. Really, the goal for these treatments is going to be to improve the symptom burden and then hopefully improve how you're feeling and your overall quality of life. There are three main options for treatment: hormone therapy, non-hormonal medications, and lifestyle changes. You can use any of these alone or in some combination with each other, and we're going to discuss each of these kind of three different options in more detail. So the first is menopause hormone therapy. This is one of the oldest and most effective medications for treating menopause symptoms, particularly hot flashes and night sweats. It used to be prescribed widely. If you went through menopause, you were on hormones because they thought it was this fountain of youth and that it was going to preserve the health of the aging woman forever. In the early 2000s, they did a study to see if hormone therapy was actually benefiting these older women. And what they saw is when they started it in someone who was older, far out from menopause, and had other health issues underlying, that there was increased risk of heart attack, stroke, and certain cancers. Even though this was really happening only in that select group of older women, it did scare a lot of doctors. And you can see that the amount of hormone therapy that we are prescribing really dropped. It's because we weren't having a nuanced thought. We were realizing that the same study showed us that women who were young, early in menopause and healthy were safe and weren't having the same bad outcomes. Since that time, we've had other studies that have come out, again, supporting that menopause hormone therapy is safe if you're young and healthy. And the medical community has started to adopt and embrace that more nuanced take where we know that it's safe for some, but not for all. But I want you to be aware of this kind of shift that's happened over the last 20 years, because Some doctors may still be holding on to some of that old teaching they had, where they're a little bit scared of hormone therapy. The way we're using hormone therapy is also different in the last 20 years. So the goal is not what it used to be before. All the forms that we use, we're not trying to replace your estrogen and your hormone levels to where they were before you went through menopause. Rather, we want to find the lowest possible dose of hormone that's going to control symptoms and help you feel great. And there's a lot of different ways that we're delivering menopause hormone therapy. It's available to be taken orally as a pill. It's available as forms that go on your skin, topical, so a patch or a gel. And then they also have forms that are a cream that acts just at your vagina and nowhere else. So the pills and those topical forms are going to be really great for hot flashes, night sweats, and then addressing bladder and vaginal symptoms. Whereas the local vaginal forms aren't going to help with some of those other systemic things, the vasomotor symptoms, but are going to be a really great option if you're struggling a lot with your urinary system. This is because the estrogen effect the body sees varies with the form you're using. So we see the highest estrogen in the pills, lower estrogen level in the skin patches and gels. And then with the vaginal form, we don't see any estrogen in the body. It's really just acting locally at your tissue. What this means too is that the clotting risk is different. So higher with the pills, lower with the patches. And because of that, most doctors, if you're wanting to try hormone therapy, are going to recommend that you start with a patch first because it's felt to be low risk. If you're someone that the doctor is really worried about any of these things because they think your clotting risk is so high, you can still treat any urine or vaginal symptoms with the local forms without having any risk for your heart or for blood clotting. Overall, when we talk about who should avoid menopause hormone therapy, it's really, we're thinking about who is at risk of getting acquired heart disease and who's at the highest risk of a clot, a heart attack, or a stroke. So we recommend not using, if you've had a history of a lot of those things, right? You've had a heart attack before, you had a stroke that happened without a good reason for it to happen, or a clot that happened without a good reason for it to happen, or you have known clotting disorders. We say to be careful if you're someone who's at medium risk of heart attack. And we know that there are things that put you in sort of a medium risk, like having blood sugar, blood pressure, cholesterol issues, or being a smoker. The good news for people who fall in this camp is that these are things that if you work with your medical team, you can help make better, right? You can quit smoking, you can get on blood pressure medication, cholesterol medication, diet or medication to control your blood sugars, and that's going to help make these therapies safer for you. And then we say anyone who's young, less than 60, early in menopause, less than 10 years since their last period, and has a low risk of heart disease should be safe. The caveat for this is that when we say low risk of heart disease, we're meaning blockages in your coronary arteries and heart attack. We don't know how to define the risk that's associated with having congenital heart disease. And this is because we've never studied menopause hormone therapy in women with congenital heart disease. A lot of the things that we advise about related to women's reproductive health is related to estrogen and our fear of clot. Even though with these therapies, we're trying to use the lowest possible hormone levels in the safest forms, we know there's still some clot risk, even with those patches. We don't know exactly how high it is. We know that the amount of estrogen you're seeing is lower than if you're taking an estrogen-containing birth control pill or while you're pregnant, because the estrogen in your body is lower. But we don't know quite how high the clot risk is, quite how high the estrogen is, and if there are particular subgroups of women with congenital heart disease who are at highest risk for clot, who really should avoid this therapy. I think this is an area that we definitely need to study and learn more about. But certainly, if you're wanting to go down this route, you should be discussing the possible risks with your cardiologist and your primary care doctor or gynecologist before starting hormones. There are a lot of great non-hormonal options on the market. So the newest medication is something called Veoza that I think is really exciting. It's the newest drug that treats those hot flashes and night sweats. And it's interesting because it targets directly the receptors in the brain that cause hot flashes. Because of this, it's so much more effective than some of the other non-hormonal options and is felt to be about as good at treating hot flashes as hormone therapy. It's a newer drug, but in the time we studied it, there's no known cardiac issues, but it's not safe for people who have really advanced end-stage kidney or liver disease. And one of the other things that's hard about it is because it's so new to market, only brand name is available, which can make it expensive. Right now, Medicare and Medicaid are not covering Veoza, but if you have private insurance, there is an online coupon through the manufacturer's website that can help bring down the cost and make it a little more affordable. Before Veoza hit the market, SSRIs and SNRIs were a lot of our mainstay of non-hormonal therapy to address menopause symptoms. So these are medications that you may hear about as being used to treat depression or anxiety, things like Paxil, Lexapro, or Effexor. But there's evidence that they help to treat hot flashes and night sweats as well. And for people who are having anxiety or depression flaring up related to their menopause, it's really great for them as well because it'll help target those mood changes. From a heart standpoint, it can have impact on your EKG. So it can prolong your QT. This is important because certain heart meds, especially ones that treat rhythm issues, may do that as well. And some people may have baseline really long QTs where their heart doctor would be nervous about them starting these medications. So you should discuss with your cardiologist if they're safe for your heart and your heart rhythm first. And then anytime planning to start them, make sure you get a baseline EKG before starting and that your team is kind of monitoring as you're starting your therapy and doing any dose increases. The last commonly used non-hormonal medication is gabapentin. Usually it's something we think of as being used to treat nerve pain. It can also treat seizure disorders. And it's thought to be an alternative to some of those antidepressant medications for treating your hot flashes and night sweats. There are no common cardiac side effects. What most people will get is a little bit of dizziness or drowsiness, especially if they're using higher dosing. That drowsiness might be really helpful, especially if you're having disturbing night sweats, because it can help you sleep better through the night. I mentioned just because it can be for some a barrier to getting it, that while gabapentin is not a controlled substance for the federal government, there are 6 different states that consider it a controlled substance and track its prescription. It may require contract between you and your doctor if they're prescribing it to you. So that can make it sometimes a little more cumbersome to get. And then last are some proven lifestyle changes. So these are all things that you can do to help decrease severity of hot flashes or night sweats. Dressing in light, loose layers that you can take on and off as you're as you're flashing. Avoiding alcohol, spicy foods, and caffeine that tend to make hot flashes worse. Trying to make your surroundings cooler. This is especially helpful for night sweats, keeping your bedroom colder. And then relaxation activities like therapy, hypnosis, or yoga. I think there's a lot of buzz around dietary supplements. I know tofu and black cohosh were some I heard a lot about, but there's so many people touting so many supplements today. Those don't have as strong evidence behind them. And I think it's important to always talk with your doctor if you're interested in starting a supplement, because many of them can interact with your existing medications and make your medications less effective. Finally, we'll talk a little bit about menopause and acquired heart disease. So, as we mentioned, we really haven't studied menopause in our congenital population at all. But we know that women tend to lag about 10 years behind men, and when they start getting acquired heart disease like heart attacks. When we look, what we're seeing is that the rate of having this acquired heart disease really picks up right after menopause. And this is because while menopause doesn't directly cause heart disease, the changes in your hormone levels cause changes in your body and its metabolism that can impact your heart health. So you can get stiffer blood vessels, including those that are supplying the heart muscle, your coronary arteries. You can have higher risk of being diabetic or pre-diabetic. Your blood pressure may go up. You have less lean muscle mass and more fat mass, particularly around the middle part of your belly. And then it changes your cholesterol levels too, where you tend to have higher bad cholesterol levels and your good cholesterol doesn't work as well for you. All these things together can contribute to having um, plaque buildup in the arteries that supply your heart and increase your risk for heart attack. I think Anitra had some pearls she wanted to share.
Just simply that, and I think Dr. Andres, really hits home here. But I think to our CHD community, sometimes we don't spend enough time with anticipatory guidance, right? And many people on this webinar may be, in fact, years and years away from actually hitting menopause and or perimenopause. And so one of the messages to look for is, tell your doctor if you've recently, for example, been diagnosed with polycystic ovarian syndrome, PCOS, or glucose intolerance, or other types of, maybe you have a strong family history tending towards heart disease or dyslipidemia. In those cases, it may give us an opportunity years before to start working on those problems, sort of in anticipation of the fact that we may be swimming a little bit more upstream when we hit menopause, due to the fact that these changes are coming around the bend. So just to kind of keep that in mind. Sometimes we kind of tend to focus on whatever heart problem or congenital heart problem, but make your doctor aware of other things that you may be being treated for or worked up for by your primary care physician.
This is great because it gets into what can you do, right? It can be really scary to hear, I'm going to go through this life change that I can't do anything about, and it might make my heart health worse. But there's so much that you can do. And Anitra is right. You want to start doing it early to help keep your heart as healthy as it can be, right? Exercise, eating a healthy and balanced diet. If you're smoking, quitting, knowing what your target numbers are. So, what's a good blood pressure for me? What's my ideal weight range? What's my cholesterol goal? What's my blood sugar goal? And really keeping that regular care with your primary care doctor so that they can be monitoring these things. And I'll say that I think what's hardest is just like Anitra mentioned, once you hit menopause, you feel like you're rowing like against the current. Your body feels like it's working against you. And I'll say that there are people who can hit that age and be as great as they want with their diet, their exercise, and they may still not be able to get some of these numbers in range on their own. That doesn't mean that they're failing. It just means that they need some extra help to keep their heart healthy. And finally, we always want you to be seeing your cardiologist regularly. That shouldn't change just because you're hitting menopause. Do you have other points you wanted to add here, Anitra?
No, I think you've summarized those beautifully. And I think what's really hard is our body doesn't tell us, oh, this symptom is from menopause, so go see this person. This symptom is actually from your heart, go see that person. And so we really want that sort of interplay between our primary care physician or other specialists who may be there, that coordination of care with your ACHD physician so that we can make sure to be holistic in this, in addressing this.
All right.
And without further ado,
Oh, we have,
after your summary slide,
yeah.
we have a wonderful surprise for everyone.
So if you guys come away with just a few things to remember, I'd like you to remember menopause transition is long, right? It can last years, that the symptoms are varied but common. It can also last for years after your period, and you don't need to suffer in silence. I think we're doing a really great job about that now, talking about our symptoms, sharing about them. Um, and you can be proactive to ask your care team, hey, this is bothering me. What can I do? And know that there are a lot of lifestyle changes as well as medications that can help address these symptoms and make them more manageable. Do be aware that there's no evidence about the safety of hormone therapy in women with congenital heart disease. This is a problem that Anitra and I want to try to fix so that in the next, 5, 10 years, we can have some better evidence to share with you all. But until now, just discuss those theoretical risks and benefits with your doctor, and that you should feel empowered that even though there's this higher risk of acquired heart disease after menopause, there are things you can do even starting now to decrease your risk. So I'd like to say thank you to ECHA for allowing us to be involved on this talk, as well as two of our colleagues at Stanford, Karen Adams, who is a gynecologist who specializes in menopause, and Eleanor Levin, who is a cardiologist who again specializes in managing cardiac health around the menopause transition.
Well summarized, Dr. Andres. I mean, could not be more grateful for this wonderful overview. And the surprise that we were alluding to is we are fortunate to have a peer mentor, Kathleen, who would be teaching us today about a patient perspective and her story. Take it away, Kathleen.
Thank you. Thank you for inviting me. I don't know if I'm a teacher. I have experience. I'm 68 years old now. During the changes that were going on in my life during the perimenopause phase, I was not educated on what perimenopause and menopausal symptoms are. So this was a great webinar for all of you to experience. I had to learn the hard way by developing urinary tract infections that I never had before, vaginal dryness, that there was discomfort with intercourse, irregular periods, and some clotting. And slowly, through the years, I realized that those are treatable. There's things you can do, but at the time, I had no knowledge of it. Um, at the same time, something pretty significant in my life was I was experiencing bouts of some of the physical manifestations of anxiety. I did not have a history of anxiety. So my logical brain was saying, what is happening? Why am I feeling anxious and vulnerable and dwelling on some of my heart condition, about some of my conditions that naturally I had to be aware of and get treated, but I was feeling very uncomfortable and worrisome to the point that I actually started having panic attacks. At the time, anxiety in 2005, 2006, it wasn't a common conversation with doctors and cardiologists. So I had to be my own advocate. And I knew that this very slow, insidious form of anxiety that ultimately developed into panic attacks was so puzzling and so odd and so life-changing that I had to get help. So I knew that that wasn't normal. Um, I didn't know that my amygdala was being triggered by all sorts of things. And so I immediately started thinking, well, my hormone levels are changing. I'm a prime candidate to have heightened anxiety because of the hormone levels. These were questions I had in my mind. And then I thought, this is definitely affecting my heart condition. And why do I say that? Because when I decided, I told my cardiologist, I need help. I think I need to see a psychiatrist. It's not normal to have panic attacks. And so I did see a psychiatrist, and he educated me on anxiety. And I had cognitive behavioral therapy. I started at the time SSRI, and I saw my gynecologist, and she recommended that I stay on the SSRI through perimenopause so that once I complete the menstruation process and I stop my periods, that I would and go through fully the menopausal years, I guess is the best way, that I would pull out of it pretty well. So I 100% had great success with my treatment. So I did not suffer long term with panic attacks or anxiety. I knew it was something that we shouldn't live with. I knew that it was aggravating my heart symptoms, and I actually had ventricular tachycardia triggered, and then my ICD would shock my heart. So it was more dramatic than most people. In my case, I had a pre-existing condition, which was my congenital heart, which was my VT. And sooner or later, all of that got addressed. But just to encourage you all that there's light at the end of the tunnel. It doesn't have to be horrible. I have to say that the years after I got treatment and dealt with my anxiety, I was actually doing and am doing pretty well. So that's my story.
Thank you so much, Kathleen, for allowing us to learn from your experiences as a patient advocate and encouraging other patients to do the same. We really appreciate you taking the time to be here. And thank you to Dr. Romp and Dr. Andres for your very informative, timely, and hopeful presentation about this change in our lives. At this time, we would like to go ahead and open the floor up for questions and answers. So just as a quick friendly reminder, you can send them through the Q&A folder on your control panel. And please remember to keep your questions general. And we have several already. So let's go ahead and begin. Cindy asks, if I had a stroke as an infant in 1974, am I at increased risk using HMT?
Mm,
And
That's a
Anitra.
great question. Oh, Anitra, go ahead.
You go ahead. Now go right ahead.
I think what is really important is understanding the situation around the stroke. Was it clotting based? Was it bleeding? Was it something that was triggered, right? Surgery, medication, something like that, versus more spontaneous? Because when we're talking about avoiding hormone menopause therapy because of a stroke, we're really talking about an older adult who had an ischemic stroke. And usually we're wanting to avoid it in those people because they've built up a lot of plaque and stuff in the arteries that are supplying the brain. And so it's kind of raising those red flags for us. Your reasons for a stroke as a baby were probably quite different. So I think it'd be important for your team to consider exactly why it happened, and then from that, better understand what your unique risk factors are.
Thank you, Kristen, for sharing that answer with us. That was very helpful. Our next question is from Donna. I've tried antidepressants and they gave me the shakes. I take gabapentin for pain, but it does nothing for my hot flashes. I did have a stroke, so frustrated. Hot flashes are horrible. Can anyone speak to anything that might be helpful to Donna while she navigates those challenges?
Yeah. So I think the new medication, Veoza, that's on the market is something that, because it's so new, just came out in 2023. Providers may not be as familiar with, but now you are, Donna, so you can ask, hey, I heard about this new medication that's supposed to be really great for hot flashes and not supposed to be so bad for my heart. Um, do you think it's a good option for me? The other thing I'd say is that GABA tends to need to be at pretty high doses for the hot flashes and night sweats. So that's something you could discuss with your team too. Are you taking a much lower dose for nerve pain? And if you went on higher dosing, may you be able to have improvement in those vasomotor symptoms without having bad side effects?
Thank you, Kristen. That's very helpful. All right, our next question is from Allison. Can someone switch from HRT to Veoza, and any thoughts on that change in medication?
Yeah, so you can. I'll say that I've never prescribed that for someone, but it would be, I guess, partnering with whoever is prescribing for you, your primary care doctor or your gynecologist. to talk about making that transition. And then I would just be aware to Allison, like I said, that depending on your insurance, it could be a very expensive medication out of pocket.
And some of the other effects that maybe the hormones that are giving you, or maybe that you were placed on those hormones originally, may not be there. I mean, to remember that Veoza is for the hot flashes, but the other things that can come from various levels of hormone therapy, either if it's systemically absorbed in some cases versus the patch, they're all going to give you different things. So, for example, the more systemically absorbed, um, say, for example, the estrogens may do a lot in terms of bone health and other dyslipidemia aspects, but you may not necessarily get that from Veoza, which is really just targeted for the hot flashes. So just to keep those things in mind as when you're speaking with your provider, what symptoms are you hoping to ameliorate?
Thank you. That was very helpful. Our next question is from Carol. She says, "Hi, I am 50 years old, and she is a CHD patient. She has PH and takes medication for AFib. The hardest part for her is knowing whether or not it's the meds or CHD or menopause. I guess the answer is a little of all. I
Mm.
wanted to share this with you providers in case you wanted to add any thoughts to that."
I think that what you're saying is the boat a lot of people feel, right? That it can be very challenging to understand, is this my heart or is it something else going on? And that the time that menopause happens in your life also tends to correlate with times where people with congenital heart disease may be experiencing changes in their heart health, which can make this an even more complicated picture. I think this is why, as Dr. Romph was saying, it's good to have a strong care team, right? Your cardiologist should not be your primary care doctor and your gynecologist and your psychiatrist. Like, you need to have a really great primary who's going to be more available oftentimes than your cardiac doctor to talk about these symptoms you're experiencing. And then they can help with some of that triage to your cardiologist. Or if you feel like they just didn't have quite the right answer, I'm not convinced that they knew enough, you can always ask, but it's best to work in collaboration.
That's very helpful. Thank you, Dr. Andres. And our next question is for Kathleen from Karen. She says, "Thank you for sharing. How long were you on SSRIs for, and did you struggle with any side effects?"
I didn't struggle with side effects. I tried a few and had nausea, and then I found one that slowly, incrementally increased to a fairly low dose anyway. Um, and that worked fine. I don't think for me that the medication in itself was 100% of a cure. I really believe the cognitive behavioral therapy, in addition to the medication, helped. And how long did I stay on it? I have a tendency to have a sort of anxiety about medication in general. So it took me a bit of time to say, oh yeah, I guess I do need to do that, take something. And then it took me a while to say, okay, now I can stop taking it. And so it was about 10 years that I stayed on it. And I probably didn't need to stay on it as long. And I think there's better treatments now, different SSRIs, like was discussed tonight. But that's what happened.
Thank you for sharing your stories more with us, Kathleen. Appreciate it. Um, a question for Doctors Andrus and Romph. How is menopause different for people who don't have a thyroid? Is there any difference?
So both my mother and sister have autoimmune thyroid disease. So I know much more about the thyroid than a cardiologist probably should because they ask me lots of questions. Um, Estrogen impacts thyroid hormone production. So as your estrogen levels change around things like pregnancy or menopause, it also is going to impact your thyroid hormone levels some. So if you have an underproductive thyroid, as your estrogen levels drop, you may make less active thyroid hormone and have a little bit worse of that low thyroid symptom. So that's something to let your endocrinologist, your primary, whoever is managing your meds know about. So that if you're starting to get some symptoms of your thyroid being low, they might need to do adjustments of your medication as your native thyroid function changes.
Thank you, Dr. Andres. That's very helpful. And our next question is from Kelly. Is there any evidence of CHD patients going into menopause earlier than the average women?
This is a very interesting question that we don't know anything about because there are no studies right now for anything in women with congenital heart disease, right? Timing of menopause, treatments, acquired heart disease risk, like if any of this holds up. So this is what we want to do. The only patients I can say for certainty would be considered to be congenital heart disease patients that would enter a menopause state early would be patients with Turner syndrome who have primary ovarian failure. So they never quite hit normal puberty without help of hormones, and are not creating the same estrogen levels. So they are sort of born almost with this menopause type state.
Thank you, Dr. Andres. That was very helpful as well. Um, our next question is also more of a statement. There are a few comments regarding studies. Do you know of any studies that women who are CHD patients in that perimenopause, menopause season of life would want to explore? Is there anything that you know of?
There's nothing existing. I say that because we want to study it more.
And it's a great problem to have, right? We didn't have that luxury before of large numbers of our patients surviving well into advanced age. So we never had this luxury. And so a lot of what we know are things about menarche and menstrual cycles and then pregnancy. And now we need to catch up with the success stories that are here and really understand. And so it's very timely, right? Because we also don't know this larger question for women without congenital heart disease. And so we want to improve our risk stratification. We want to understand more. I think some of the lessons learned are this potential for timing hypothesis that if we could target a subset of women or all women in various capacities, sort of earlier in that menopause, perimenopause transition, and potentially even start treating some of the symptoms to improve at the very least quality of life. But really what we're looking for in the long run, the holy grail of things is really to really trend towards positive cardiovascular health and not be that other statistic, which is that women develop heart disease sort of, 10 years later or whatever than men. More to come. Stay tuned. We're very excited about this area.
We're very excited to have two great providers interested in this area and speaking to us about this topic tonight. Our next question is for a CHD patient on Coumadin who is unable to take MHT, can you please explore some alternative options that may be helpful to them, maybe lifestyle?
Mhm. So I think it's really going to be those non-hormonal and lifestyle medications. In speaking with um, Dr. Adams, who's our expert in menopause from the gyne perspective at Stanford, she really loves Veoza. I think again, it depends on what's your insurance, what's your budget, but it seems to be a medication that is really as effective for hot flashes um, as hormones are. And I think it's one that potentially has a lot of promise for women like you who have been told for whatever heart-related reason that hormones are off the table for them. Beyond that, I think if I'm breaking down medications, that the SSRIs tend to have a little bit better effect than gabapentin, but those are two kind of classes of medication that would also be possible to try to help control hot flashes better. And that as far as lifestyle changes, things we talked about, trying to manage the temperature around you, not wearing big, heavy clothes, avoiding alcohol, caffeine, spicy foods have all been shown to be quite effective. And if you're overweight or obese, sometimes losing weight can also help with severity of hot flashes, which I know can be easier said than done.
Thank you, Dr. Andres. That was very helpful. Um, our next question is from Yvette. Can menopause cause short runs of SVT?
Mm. A good question that again, we don't have any evidence right now to say that menopause in and of itself causes arrhythmias, right? We have like one study in women who had structurally normal hearts that said when they were feeling palpitations, that those palpitations weren't arrhythmias. But I don't have enough data in the congenital heart population to know for sure. It's, I think, going to be hard. It's going to be one of those chicken and the egg things, right? Are you having runs of arrhythmia because of hormone changes of menopause? Are you having runs of arrhythmia because you've hit an age with your congenital heart disease and your surgery where things are changing in your heart and your repair? A little hard to know for sure.
I agree completely. And I think what Kathleen's story tells us is that there can also be two things going on. There can
Mhm.
be the anxiety, depression that could be around the menopause stuff, but then it's also normal to be anxious if you're having real arrhythmias, right? Am I right, Kathleen? So I think,
Mhm.
treating both and with the spirit of saying, hey, both things could be going on here. Let's attack both and let's see, let's investigate at the same time as we're addressing these other symptoms that can pop up during menopause, I think are the key.
Yeah, it was really important for me to address the rhythm issues, the palpitations, and so forth. I was aware of many more palpitations, but I also knew that I have a heart condition, and I didn't really put the two together, but I knew that the anxiety could aggravate the palpitations and bring on some of the other issues. So it was sort of dealing with both issues and not blaming one thing for the other, but really just looking, I have this and I have this, and they don't go together very well. They need to be dealt with very, very seriously. They need to be dealt with. And so I did it that way.
Oh, thank you so much for all of your responses to that question. Unfortunately, this will be our last question. Thank you all so much for your great questions and your positive comments to our presenters. For our last question, any suggestions regarding losing belly fat while being an ACHD patient with limited exercise capacity, since belly fat is a concern for acquired heart disease?
I I think that exercise is always important. We love exercise, but we know that diet oftentimes plays an even bigger role in body composition and body fat than just exercise alone. So I'd say um, maybe working with someone like a dietitian or a nutritionist to try to help make sure that you're making heart healthy um, choices that are going to be within kind of a caloric or energy goal to meet your goal for weight loss while still giving you all the nutrients that your body needs to run. Um, that also as we're looking more into links between, weight and heart health, that there's a lot of medications that are on market. Some of these weight loss medications, the semaglutides, the Wegovy's, that patients have found very helpful. and sometimes depending on their heart disease may even be able to have assistance getting covered, even if they don't have a blood sugar disorder, which is what they were usually prescribed for.
And I would additionally just add that, muscle strength, I know we tend to focus on the one thing, that belly fat, but maybe focusing off of that, working on muscle strength and core strength, which is often,
Mhm.
impaired and things like that, from our various surgeries and things like that, that many congenital patients experience. And so that's going to help with our bone health, number one, and two, injury prevention as we age. And then sort of collateral damage will be, hey, that belly fat can gradually go away, but if we shift our focus more towards overall cardiovascular and strength training exercises, we may be able to help a lot of things in addition to the medications that and diet that Dr. Andres mentioned.
Just because it's a passion thing of mine, Mary asked a question that I want to answer as well. She was saying that she felt kind of brushed off by how to address her menopause symptoms by her primary care provider, just saying that because she has heart disease, she's not a candidate for HRT,
Mhm.
and that she's a TET. And I'd say that this is one where I would really talk with your cardiologist, because in my mind, heart disease is so nuanced and specific between each and every one of us that I don't expect your gynecologist or your primary care doctor to know what level of estrogen is safe for your heart, right? And even now, your cardiologist with this medication is a little bit in no man's land. But
Mhm.
if you were someone who your cardiologist said you can go forward with a pregnancy and you had a successful pregnancy, if they said you can take a normal birth control pill with estrogen and I feel safe with you doing that, there's also a good chance that your cardiologist would say, unless you have some of these other outside of your congenital heart disease red flag risk factors, you were safe for those higher forms of estrogen. You should probably be safe for this lower form too. And having that conversation and collaboration with the primary care doctor may help them understand how your heart disease fits differently outside of the algorithm they're used to, which is all focused on heart attacks and a different kind of heart disease.
Mhm.
Well, thank you so much again, everyone, for your wonderful questions. I learned so much. This has been very helpful for me as well. Thank you again to Doctors Romph and Andres for your hopeful and helpful presentation on this very important topic. And again, thank you to Kathleen for being vulnerable and brave and sharing your story and allowing us to learn from your experience. So appreciate all of you. Um, so this does conclude our webinar this evening. I want to remind everyone that the webinar was recorded and will be available on our website later this week. And can we go to the next slide really quick, please? Thank you. And thank you again to Abiomed and Johnson & Johnson for their support of tonight's webinar through an unrestricted educational grant. An evaluation will pop up in a separate window on your browser after the webinar closes. If you missed that, there will be a link in the email that you'll receive tomorrow. Thank you in advance for completing the evaluation. Your input is very important to us, and we appreciate the time you take to fill that out. All right, last slide, please. Yeah, okay, good. A few final thoughts. If you would like to talk to another person with a congenital heart disease or a loved one of a CHD patient, or if you have questions or concerns that one of ACHA's peer mentors can help you with, please email info@achaheart.org and someone will contact you. If you need to find an ACHD program, you can visit the ACHA clinic directory available on our website. You can also read Dr. Romph and Dr. Andres's full bios on our website as well. We hope that you will join us for our summer Walk for 1 in 100 season with walks in Delaware Valley, Pennsylvania on June 7th, in Denver, Colorado on August 17th, or you can join us for our virtual walk on June 14th, A full list of walk locations is available on our website. Thank you again for registering for tonight's webinar. We hope you enjoyed it. If you did, please consider making a donation so we can continue to bring you great educational resources and information. All right, everyone, have a wonderful Wednesday. Take care.
Thank you, Carla.
Thank you.
Thank you. Good night, everyone.
Kathleen.